Dr. Andrea Garrod, and I'm here to talk about respiratory disease and ciliary dysfunction in patients with heterotaxy. I am a pediatric pulmonologist and the primary ciliary dyskinesia center director at the University of Virginia. Thanks for having me. So in our talk today, we'll cover some big headlines. We don't have much time together, so I'll try to get through all the content and hopefully not rush too fast, and then have questions when we all join back together in the end. So we know that patients with heterotaxy have lower lung function. Here's our first headline. All right, so what is lung function? When I say lung function, what do I mean by that? So in pulmonology, we review pulmonary function tests. This allows us to have some degree of objective measurement for patients' lung disease, and we use it to evaluate symptoms and to evaluate response to therapy. In the following slides, I'm referring to this type of pulmonary function testing. So this is a study from 2019 that looked specifically at lung function in patients with congenital heart disease. They found that about 1/5 of children with congenital heart disease will have some impaired lung function, and that those with impaired lung function had some predictor of mortality associated with that. And then that specifically a restrictive pattern correlates with problems with exercise capacity as well as quality of life. They looked over different types of congenital heart disease, and logically, patients with a more complex congenital heart disease, such as heterotaxy, had significantly lower lung function as compared to other groups. This is another study from 2017 that compared patients that are healthy to those with primary ciliary dyskinesia to those with Fontans. And then they separated the Fontan group into those with isomerism and those without isomerism, using isomerism as a marker of heterotaxy. So the groups here are relatively small in their total number, so take it all with a grain of salt. But similarly to the last group, the patients with Fontan physiology, so congenital heart disease, had significantly lower lung function, specifically restriction. Those with PCD had a little bit more obstruction as compared to the other groups, certainly as compared to the healthy groups. And interestingly, there wasn't a huge difference between the Fontans with and without isomerism, but those with isomerism actually had slightly better lung function. We also know that patients with heterotaxy have more post-operative respiratory complications as compared to those with other types of congenital heart disease. So this study compared all patients with congenital heart disease and took patients with heterotaxy compared to other types of congenital heart disease. And then using a standard risk adjustment, matched similar patients to their severity. So we're equally severe types of congenital heart disease, but some with and some without heterotaxy, and compared outcomes in those two groups. They found that those with heterotaxy as compared to non-heterotaxy congenital heart disease had more respiratory complications like needing mechanical ventilation, tracheostomy placement, and ECMO, as well as having increased mortality and longer lengths of stay in the hospital compared to those without heterotaxy in congenital heart disease. Which brings us to the why. Why do we think our heterotaxy patients might be having these pulmonary complications and issues with lung function? So we know that cilia looks to play a role in the development of congenital heart disease, and the beginning work of that model came from Cecilia Lowe's lab, and she will be speaking with you guys tomorrow and will be able to speak to this much better than I can. But when I was a fellow in training, I had the pleasure of being in her lab. And at that time, this article from Nature was published about the role of ciliary genes in the development of congenital heart disease in a mouse mutagenesis model, which certainly got me thinking as a trainee a lot more about this. So why are we talking about cilia, and where is cilia located in the body? So cilia are located anywhere in your respiratory epithelium as well as in your embryonic node. The image on the left is ciliary motility in an airway, and that's normal motion. You can see kind of sweeping motion, sweeping mucus out of the airway. The other image is in the embryonic node. In the embryonic node, the structure of the cilia is slightly different, and because of that, the cilia move differently. So compared to that wave motion, they kind of move in a rotary motion, and that determines flow within the embryonic node, which changes the dynamics between left and right. So the thought is that this determines your left and right access in the body. Which brings us to a slight bit of a tangent about primary ciliary dyskinesia. So primary ciliary dyskinesia, as described, is a disease where cilia do not have functional movement, have dysfunctional movement. And because of that, we see both pulmonary respiratory symptoms, as well as differences with things like organ situs arrangement and heterotaxy. So this will all come back around to heterotaxy. So we talk about organ laterality. We're just talking about the embryonic node and flow within that node. In an absence of flow, which would occur in patients with that dysfunctional motility or absence of motility, so there's no flow in the embryonic node, your organ situs is going to be random. So in patients with primary ciliary dyskinesia, they estimate a little under half to have situs solidus or normal organ arrangement, a little under half to have sinus inversus totalis, so mirror image organ arrangement, and about 12%, and this number can vary across studies, to have situs ambiguous, meaning random arrangement of your organs on the left and right side of your body. And it's in this category of situs ambiguous that we'll see patients with heterotaxy. So how do we diagnose PCD? First, you have to have the phenotypic feature. So do you have signs and symptoms that suggest you have PCD? And if so, we move on to diagnostic testing. There's no single test that captures all PCD patients to have a diagnosis. So in the testing protocols in general, the more number of tests you have that are positive, the more likely it is that you have primary ciliary dyskinesia. And some appear to be more definitive than others. I talked a little bit about the signs and symptoms. So patients with PCD generally have neonatal respiratory distress. About 80% have neonatal respiratory distress. Nearly all of them will have a daily productive cough. Most of them will have chronic sinusitis, chronic rhinorrhea, recurrent otitis media, and then later develop some bronchiectasis. There's also different types of findings we can find in other parts of the body, like issues with fertility and hydrocephalus. When we're trying to decide who to test for PCD, the recommendation is that patients have at least 2 of the 4 of the following typical features of PCD, those being that respiratory distress, year-round daily wet cough starting before 6 months of age, year-round daily nasal congestion starting before 6 months of age, or an organ laterality defect. So in our patients with heterotaxy, you can imagine they would meet the criteria for organ laterality defects, and many of them have neonatal respiratory distress. The hard part is trying to determine whether that distress is associated with a cardiac disease or whether it's respiratory disease. But certainly once we start seeing the sinus and lung symptoms, we get much more worried. How we do the diagnostic testing can be by genetics, by nasal nitric oxide, or by testing ciliary ultrastructure by electron microscopy. Less commonly in the United States, more commonly in Europe, they'll do ciliary motion and waveform analysis by high-speed video microscopy. And in some labs, they'll do immunofluorescent staining. Nasal nitric oxide testing at this point is mostly available in specialty centers like PCD centers. To do that test, you have to be able to follow directions, at least to do the most typical technique that we do in patients over the age of 5. So the patient has to blow against a resistor, and they have this little tube that goes into their nose attached to this foam piece. And that tube very slowly draws air out of the nasal cavity and tests the amount of nitric oxide in it. And in patients with primary ciliary dyskinesia, that number is lower compared to the general population. All right, so now back to our heterotaxy patients. So what do we know specifically about ciliary dysfunction in patients with heterotaxy? So this was a group that looked at ciliary motility, nasal nitric oxide levels, and respiratory symptoms in patients with congenital heart disease with heterotaxy. So they looked at a large cohort of these heterotaxy patients and studied these sort of typical PCD type findings, and found that many patients with heterotaxy had abnormal ciliary motion on high-speed video microscopy. And then they also did those nasal nitric oxide levels. So they found that in the patients with heterotaxy that also had abnormal motion, those patients had lower nasal nitric oxide levels, more respiratory symptoms, and more complications in the post-op period. They had more beta agonist use, so they received more albuterol, they had more trachs placed. And so this is compared to heterotaxy patients that had normal motion. So this entire group was just heterotaxy patients, but those that had abnormal motion also seemed to have more respiratory findings and more findings that would suggest they had a primary ciliary dyskinesia type picture. So this is work that I got to do as a fellow in Dr. Lowe's lab. We looked at ciliary dysfunction in both heterotaxy and non-heterotaxy congenital heart disease. And then similar to the last study, we looked at those two groups, heterotaxy and non-heterotaxy, and divided them up by whether or not they had abnormal or normal ciliary motility, their nasal nitric oxide levels, and also did a questionnaire for respiratory symptoms. In our group, you can see in these diagrams that in general, the heterotaxy group had more abnormal findings. So in the corners there, you can see the heterotaxy group, about 20% had both normal motion and a normal nasal nitric oxide level. And in the non-heterotaxy group, slightly more of them had normal motion and a normal nasal nitric oxide level. And in the heterotaxy group, there was a good percentage of patients, so 33% of patients had both abnormal motion and an abnormal nasal nitric oxide level. We then did further data analysis, also looking at symptoms, and interestingly found that heterotaxy was not an independent risk factor for the increased number of symptoms. The thing that was associated with your symptoms was the abnormal motility and a lower nasal nitric oxide level. But as we mentioned, in general, more of those patients happen to have heterotaxy. So this brings up a concept that we in the heterotaxy and PCD community have been looking at, this idea of heterotaxy-related respiratory ciliary dysfunction. So we're seeing a lot of heterotaxy patients that don't necessarily have as robust symptoms as our PCD patients, but they have many of the similar symptoms. Some of them are getting bronchiectasis, many of them are getting recurrent sinopulmonary infections, and some of them are having ciliary dysmotility and lower nasal nitric oxide levels. All right, so moving on past this question of cilia, we also know that our patients with heterotaxy get other types of lung disease for many different reasons. And what are those lung diseases? So these are conditions associated with heterotaxy that can lead to other pulmonary problems. So we know a lot of our heterotaxy patients have a suppressed immune system that can lead to recurrent respiratory infections. And those respiratory infections can lead to things like bronchiectasis and other complications. There's a lot of ways those heterotaxy patients can have immunosuppression, including things like problems with their spleen, having a heart transplant that is suppressing their immune system with medications, having immunoglobulin depletion if they have protein losing enteropathy after a Fontan, and a myriad of other reasons. If these patients are getting respiratory infections, then they should have a pulmonologist involved. Many of our patients with complex congenital heart disease are born preterm, and we know that preterm birth in and of itself can be associated with lung disease. Many of them have Fontan physiology, single ventricle physiology, and we know that patients with Fontans can have plastic bronchitis, which can be quite frightening. And in general, they seem to have more sleep issues. And then lastly, we know that kids with congenital heart disease, including heterotaxy, can have associated pulmonary vasculopathies that need to be addressed separately with the team. Sometimes what we do to treat our patients with surgery can also result in other complications. So post-surgical lung disease is quite common. In the process of the surgery, there can be nerve damage that causes vocal cord motility issues. And in patients that aren't able to close their vocal cords, they're more likely to aspirate, which obviously can cause long-term pneumonitis. They can have injury to the nerves of the diaphragm that cause the diaphragm not to move well, either on one side or on both sides. That can require positive pressure due to the respiratory insufficiency. The ventilator itself can cause some degree of lung injury. These patients can have issues with chest wall compliance and weakness from the surgeries that they've had. Pulmonary hemorrhage is a complication, and many patients that we see will have pleural effusions as well. So, the heart and the lungs are neighbors, and oftentimes if we're dealing with one, we're dealing with the other. Okay, now what do we do? So who should be on the team? What should we be testing for? How should we be caring for these patients? Is something that we're trying to work on as a subspecialty group. So this would be the team that we would recommend for patients that have pulmonary complications of their heterotaxy. So the assumption here is that you already have your cardiologist on board and your cardiothoracic surgeon, but what about the pulmonary complications? So having access to a good pulmonologist in our pediatric patients, we'd be obviously talking about pediatric pulmonology, a good respiratory therapy team, genetics to work through the complex genetic diagnosis of reasons for primary ciliary dyskinesia or congenital heart disease, pediatric radiology to look at the studies, pediatric otolaryngology to look at the complications of PCD in particular, speech language pathology to help with assessments of aspiration, dietitians to make sure our patients are growing, and social workers to make sure that we're supporting not just our patients, but the whole family in the complex care of our patients. The diagnosis of lung disease oftentimes will depend on how the patient is presenting. So we would recommend that pulmonology be consulted in all patients with heterotaxy. I think the big question here is, at what point should that be? Does it need to be at birth? Chances are at birth, we're not going to be able to see a lot of the symptoms that might point us in a certain direction. But involving pulmonology in the perioperative period, involving pulmonology when the child gets old enough to do PFTs, make sure these patients are having baseline chest x-rays. This would be sort of the baseline care that we would recommend for all heterotaxy patients. Studies to consider based on symptoms are going to be specifically tailored to the child in front of you or the patient in front of you. So if the patient has signs and symptoms consistent with primary ciliary dyskinesia, right, those pulmonary symptoms we were talking about, then we would recommend testing. There are specific guidelines for testing, but ideally get them to a center that has nasal nitric oxide testing, involve your genetics team with looking at genetic testing. And if your local hospital can run electron microscopy, that's great. There's other places you can send it out to also assess good ciliary epithelial biopsies. We would recommend chest ultrasound afterwards if these patients are having a lot of issues clearing their secretions or ventilating, or if the diaphragms are looking different on x-ray. Obviously, we need to look at their diaphragm motion. A swallow study to look for pulmonary aspiration if we're having issues with chronic cough. A chest CT in general can be very helpful whenever our patients are having chronic wet cough. Maybe, they don't have PCD, but there's other ways to be developing bronchiectasis that would really drastically change the treatment of these patients and their follow-up. Those types of things might be things like respiratory cultures, right? If we find bronchiectasis, if the patient has an immunodeficiency or heterotaxy-related respiratory ciliary dysfunction, we should be looking at cultures to make sure we're screening for problematic bacteria that could be treated before causing more morbidity. Flexible bronchoscopy should be considered in patients if you have concern about abnormal anatomy, injury to the airway, compression to the airway after some of these surgeries we certainly see often. And then watching for sleep symptoms. This is especially true whenever we have patients with baseline low oxygen saturations, and we need to be worried about pulmonary hypertension, but a lot of these patients will have sleep apnea. So taking a look out for those things and ordering a sleep study whenever it's appropriate. Management is going to depend on what you find. So if you find PCD, there's a consensus statement for therapy. We would recommend you get them over to a PCD center. Airway clearance strategies for these patients whenever they're going into the operating room or to avoid complications after surgery are important. The exact modality you might use or the medications would be up to the subspecialty team based on an individual patient. And then again, we talked about respiratory cultures. All of these patients should be seeing their primary care provider, make sure they're getting their vaccinations and their frequent checkups. How often you're going to need to be seen by the pulmonologist is going to depend on the underlying condition. But we would want to standardly follow any patients that are having chronic symptoms. And in general, just pick up the phone, call your pulmonologist, call the subspecialty center or the specialty center for PCD if you have a patient at your center that might not have a PCD center per se. We're always happy to answer a question. Just send us an email. And that is all I have for you. Thank you for your time, and hopefully I will get to talk to you all in just a minute.